Hello, Mayur. Hope you're doing good. Yeah, nice to see. Yeah, yeah. So I just start the program. Dr. Amit, Amit, Dr. Seema is logged in.
Not yet, doctor. She's disconnecting the call. I think she's going to connect in 1 or 2 minutes.
Yeah, yeah. Just please make sure that whoever is trying to come in as a participant through the Zoom app, can you just admit them, no? Based on the credentials, please.
Kavita?
Not yet, doctor. She's
Yeah. Yeah. So we'll start with the program. Am I audible, Amit?
yes, doctor. Dr. Seema also joined.
Yes, please. So, good evening to all. A big thanks to Manipal Hospitals and Manipal Comprehensive Cancer Center for giving us the opportunity to share our experiences in musculoskeletal oncology, and also OrthoTV, also where they've helped us out to reach out to many more doctors who are interested in this niche specialty. So just at the outset, I'd just like to give a small introduction that the Musculoskeletal Oncology Symposium was started in 2019. And we started locally in Bangalore and Karnataka, and we had a very good response where we tried to start off with the basics of treating musculoskeletal oncology disorders. And the sequel of that, the second edition, is MOS 2020, where the uniqueness of this program is that COVID has helped out a lot in a sense wherein we've been able to break down the series into a webinar series. And rather than having a clutter of the same, the topics on one day, we're having a lot of topics, basically 4 major topics spread out between weekly, so that we have adequate time to go through them, and also a lot of time to even reflect and try to incorporate these in our practice or for residents, even in the exams also. So unfortunately, Dr. Somshek, who's the chairperson, is not available today. So I'll be taking charge of moderating the session and the introduction also. So I'd like to just give a brief outlay of today's program. Yeah. So our program schedule for today is going to be focusing on radiology and benign bone tumors. So we have Dr. Seema Janardhan, who's a musculoskeletal radiologist who's been trained in ROH in Birmingham also, and she's been with us so the last 6 years in Manipal Hospital. So she's going to share her talk on MRI in bone and soft tissue tumors. What is the diagnostic and prognostic utility? Because that is one of the most cornerstone of imaging in musculoskeletal oncology. This will be followed by a talk by Dr. Reddy Prasad, who's our interventional radiologist, and he'll be sharing his involvement. Basically, why does an interventional radiologist, or what is the role which they actually play in when we treat bone tumors, soft tissue tumors, or bone metastasis? And lastly, I would conclude this session by having a talk on GCTB, that's giant cell tumor of the bone, wherein I'd be trying to put across the treatment armamentarium. So I guess to start with, I'd request Dr. Seema, where we can request her to start a presentation. Dr. Seema, am I audible?
Hello?
Yes, please. Can you? Yeah. Can you please share your screen?
Is my screen visible?
Yes, please. If you could just go to the presentation mode, that will be great. Thank you so much.
Hi, good evening, one and all. I'm Dr. Seema Janardhan. I'm one of the consultants at Manipal Hospital. My special interest is in musculoskeletal radiology and
Doctor, can you increase the volume, doctor?
Yeah, 1 second. Is it better? Hello? Hello? Is this better?
Yes, doctor.
Okay.
Little more if possible.
Yeah, is that better?
Yes, doctor, you can.
So today I'll be talking about usage of MR in the diagnosis and follow-up of bone and soft tissue tumors. In the evaluation of bone tumors, it's a multimodality approach, and most of the MSK tumors, imaging-wise, are often initially evaluated by with X-rays. First of all, basically because they are very cheaper, readily accessible, and also most often X-rays give us quite unique and specific information about a particular bone lesion and is able to guide us to know whether a lesion needs further imaging or not. But X-rays are less sensitive, particularly in early stages of disease. And in those conditions, there are other modalities which come into picture. Bone scan is a nuclear medicine study which is used. It's a sensitive study, but it provides exquisite information about the evaluation of marrow as well as soft tissue involvement. There are certain sequences which are particularly useful to look for bone marrow infiltration. MRI is also the best tool for local staging because it helps us in a proper assessment of the extent of the disease and invasion of the surrounding structures. MRI is very good for tumor characterization, including chondroid matrix, particularly when it is non-mineralized, to look for vascular tissues. We can differentiate cysts from solid lesions on MR, and also we can identify hemosideриc tissues wherein there is hemorrhage within the lesion, which may either point towards a rapidly growing tumor or a malignant tumor. MRI is also useful for assessment of post-chemotherapy changes. So what is the protocol? Protocol is we use dedicated limb coil to assess the bone tumors, particularly when they are in the appendicular skeleton. And we use body coil if they are in the axial skeleton or if dedicated limb coil is not available. For tumor evaluation, there are particular sequences which are useful. The first one is the STIR sequence, which is the short toe inversion recovery sequence. This is a heavily fluid sensitive sequence wherein we suppress the fat signal so that the resolution, the contrast between the tissues actually stands up. This is particularly useful for picking up edema, and that edema may be soft tissue edema or bone marrow edema. T1 spin echo sequences or the fast spin echo sequences are quite useful for identification of marrow infiltration, epiphyseal involvement, and also to look for skip lesions. T2 weighted sequences, again, fluid sensitive sequences. They can be used with or without fat saturation. And they are quite useful for characterization of the lesion as well as evaluation of the cartilage, joint, as well as soft tissue involvement. Last but not the least, dynamic contrast MR as well as static T1 weighted fat suppressed sequences are quite useful to assess for the tumor viability, particularly before biopsy. Contrast also helps us differentiate between the tumor as well as the adjacent edema, which can be quite difficult to pick up on non-contrast sequences. And they are also useful for monitoring treatment and in the identification of post-surgical recurrences. So how is MR useful in identifying marrow involvement? This is an example, a case, a 22-year-old who presented with pain in the lower limb, and X-ray demonstrated a mixed lytic destructive lesion in the distal femur. And on MR, this is the STIR sequence, wherein there is a destructive lesion in the distal end of the femur, which has got a very heterogeneous appearance. The lesion has got mixed areas of low signal intensity and high signal intensity. And we're not sure as to what is happening to the bone adjacent to it. Is this matrix? Is this osteoid matrix? Or is it dead bone? What could it be? So T1 weighted image actually helped us identify a clean cutoff between the affected area here and the bone adjacent to it. The normal fat signal seen here was actually quite reassuring that the lesion was limited to the distal half of the the femoral shaft. In addition, we also get information about the periosteal elevation here, extraosseous involvement, as well as the cortical destruction. As we can clearly see, there is a pathological fracture. On the axial non-fat suppressed sequences, we identified that this was a circumferential lesion with multiple T2 hyperintense areas, which could be necrotic or fluid pockets. And also it gave us information about the invasion into the surrounding structure. So we can clearly see that this is actually causing mass effect, but not infiltrating into the surrounding muscles. And we can also identify the neurovascular bundle here with preserved fat planes between the lesion and the tumor. Staging, MR is also useful to look for the extension, either intramedullary or extramedullary. In this gentleman who was a 51-year-old patient who presented with pain in the pelvis, X-ray demonstrated a lesion, a lytic lesion in the iliac wing. And on MR, we could appreciate that this had actually gone out of the bone. It was not limited to the bone, with a small soft tissue component as well. So MR is useful for evaluation of both intra and extramedullary involvement. The intramedullary extension actually determines the site of bone resection, and the extramedullary extension, particularly in the presence of transtubercular or transcortical infiltration with periosteal extension, it can help us determine the aggressiveness of a lesion. And that actually determines the feasibility and the requirement of surgery. Surgical planning can be done, and whether the type of limb salvage can be performed can be determined before the surgery. MRI is also useful to look for joint involvement. This is a young patient who presented with a lesion in the proximal tibia. On the X-ray, as we can see, there is thinning of the cortex on the lateral aspect, but we're not sure what is happening to the articular surface here. On MR, we could appreciate that there was quite a bit of thinning of the articular surface of the tibia, and there was erosion of the bone. And on T2 weighted images, this is STIR actually, we could see that there was some soft tissue which was protruding into the joint, as well as there was surrounding soft tissue edema. So MR can actually help us in determining joint involvement. Skip lesions. This is a patient who presented with a quite destructive lesion in the distal femur. The lesion looked quite aggressive with aggressive periosteal reaction. It was limited to the shaft of the femur with not crossing across the epiphyseal bone. But on careful evaluation, we realized that there was a small focus, a hypo-intense focus on T1 weighted image. We're not sure whether what it could be. And T2 weighted image actually with fat suppression demonstrated high signal in the same lesion. So this looked quite dubious. So we went ahead and gave contrast, and this showed high uptake in this region. So this was a case of skip metastasis from distal destructive lesion. So when we actually request for MR, it is very important that we also include a long T1 or a long STIR sequence with a large FOV, and the entire limb of the entire length of the bone has to be imaged. MR is also useful for characterizing the lesions. The primary goal of imaging is always to find specific diagnosis of a lesion, thereby eliminating the need for biopsy. On plain radiographs, usually 30 to 50% of bone destruction should have taken place for us to see the evidence on X-rays of a bone lesion. But in MR, we don't need to wait for that stage. So it is quite useful in any case of neoplastic infiltration without bony destruction. So thereby it aids early detection of bone tumors. Few specific findings. This is a table where there are particular tumors which demonstrate specific T1 and T2 findings. So on T1, usually if the signal is high, it's either fat or blood, and correspondingly these lesions demonstrate.
Yeah. Hello, Dr. Seema. Your voice is not audible.
Is it audible now?
Yeah, it's audible. I think there was a small break, I guess. Yeah, please continue.
How long has it been inaudible for? Sorry.
Just a few seconds, please.
Just a few.
Then continue. Yeah, please.
Okay. So if the signal is low on, high on T2, it is usually non-mineralized chondroid tissue. And if there is low signal on T2, it could be either due to hemosiderin deposition because of blood breakdown, such as in GCT. It could be because of fibrous tissue, calcification appears low signal on T2, as well as mineralized osteoid matrix appears low signal on T2. So here is another case study, 40-year-old with thigh swelling. T1 weighted image here demonstrates a large tumor in the medial compartment of the proximal thigh region on T1. The lesion is predominantly high signal, so this means we're dealing with a lesion with either blood or fat. On T2 on stir sequences where majority of the fat signal was suppressed, the lesion demonstrated heterogeneous signal with a central suppressed area and a peripheral non-suppressed area, which means that this is a lesion containing fat as well as edema. On gradient echo or FFE sequence, as we see, this sequence is very specific for blood degradation products, and we could appreciate that this lesion actually had some blood degradation products as well as fluid levels. So this was actually a lesion which had fat component, blood as well as necrosis. So following contrast, the lesion demonstrated very heterogeneous enhancement, and this was a biopsy-proven liposarcoma. Another case where proximal humerus on plain radiograph demonstrated an ill-defined lucency. On T1 weighted image, there was a lesion which was quite bright. This is a non-fat suppressed T1 image. Note that the subcutaneous fat is bright. And upon fat suppression, the lesion demonstrated complete signal suppression. So this was an intraosseous lipoma. So MR, even without contrast, can help characterize the lesions. Another example, ill-defined sclerotic lesion in the medullary cavity of the femur. On T2 weighted images, it demonstrated a lobulated intramedullary lesion with punctate calcification, low signal areas, probably chondroid, confirmed on T1 weighted images as well. So MR can actually help characterize the signal of cartilage, particularly the lobular growth pattern. It can also demonstrate presence or absence of endosteal scalloping, which can help differentiate between aggressive and non-aggressive cartilaginous lesions, and also show us other sinister findings such as cortical remodeling, cortical breach, or extraosseous components. Another example of a growth which demonstrated a thick cartilaginous cap on axial sequences. This was an osteochondroma. And MR can also help in determining certain indeterminate lesions. So this plain radiograph demonstrated an ill-defined moth-eaten pattern of bony destruction. On MR, T1 was quite indeterminate, low signal, inhomogeneous, low signal, bright on T2 weighted images. But upon giving contrast, we could pick up that there was fluid all around the lesion here, and there were also some areas of pockets of fluid. So this turned out to be a chronic osteomyelitis, which can easily mimic an aggressive bony lesion. MR is also useful for biopsy planning, and MR should always be performed before biopsy, mainly to identify the best site for biopsy, to direct the best approach to biopsy, and to prevent contamination. And also because post-biopsy interpretation can be difficult because of hemorrhage and necrosis. So what is the role of contrast in planning biopsy? It helps us differentiate solid components from hemorrhage and necrosis, and to target these areas so that the biopsy yield is higher. And it also helps monitor chemotherapy response and detect recurrence. So this is an example of a 12-year-old child, biopsy-proven Ewing sarcoma. This was pre-chemo image where there is a large destructive bony lesion with both intraosseous and extraosseous components. And see the thickness of the lesion here. The soft tissue component was quite circumferential and thick. This is a post-chemotherapy image of the same patient after 4 cycles. We can see that there has been significant reduction in the degree of both intraosseous as well as extraosseous components. And following contrast administration, we could also demonstrate that the amount of extraosseous component which is left behind is also necrotic, which is an indicator of good treatment response. Another example where we can have diagnostic dilemmas, particularly in post-chemotherapy patients. This was a patient who had a biopsy-proven osteosarcoma in the distal femur. Following chemotherapy, we identified interval development of these tiny lesions within the medullary cavity of the femur. Obviously, the question was whether these were metastatic deposits. We gave contrast. The routine static post-contrast actually didn't give us any clue because these lesions were also picking up contrast, but not to the same extent as the primary lesion. We did diffusion weighted imaging and we realized that there was not much diffusion happening at the same level in these lesions. And I'm just showing a small clip. So we went ahead and did what we call the dynamic contrast enhancement. So what dynamic contrast enhancement is, I'll be talking about in the next couple of slides. So we actually gave contrast and monitored the signal intensity against a time curve. And you can appreciate that there are certain areas which are enhancing quite quickly as compared to the rest of the lesion. And the lesions that we were interested in higher up here, they didn't show any significant contrast enhancement, particularly in the early phases. So dynamic contrast enhancement is a non-invasive assessment of microcirculatory characteristics of a lesion, and curves are obtained by plotting signal intensity changes over time to reflect the passage of contrast agent within the tissues. It can help us distinguish benign from malignant cartilaginous tumors. Few examples are benign chondromas. They do not enhance or enhance very slowly, whereas aggressive lesions as chondrosarcoma display very early enhancement. Osteoid osteomas can demonstrate marked enhancement of the nidus, particularly in the center in arterial phase. And giant cell tumors usually demonstrate early enhancement with a steep slope followed by early and rapid washout. An example of dynamic contrast enhanced imaging, there was a lesion in the proximal fibula. So we gave contrast and we followed the lesion and we plotted a curve. Now the red curve corresponds to the artery. So that usually demonstrates a fast uptake. The yellow curve was actually within the lesion, the site of interest, which showed a delayed but a slow uptake and it reached a plateau. Now, the blue curve represented the muscle, which showed much lesser contrast and much flatter curve. So this was an intermediately aggressive lesion, which turned out to be an enchondroma. Another example of a lesion, this was a 60-year-old female patient who presented with a pathological fracture in the left proximal femur. We saw what looked like a cartilaginous tumor with chondroid matrix on T2, punctate arc and arc type of calcification. But when we actually did the contrast study, the region of interest actually demonstrated a higher and steeper uptake as compared to the uptake in the artery here. So this was a chondrosarcoma. So dynamic contrast enhanced MR imaging is quite useful to differentiate particularly between enchondroma and chondrosarcoma. This is a paper published in 2013 in European Radiology. If you're interested, you can get more information from this paper. Last but not the least, post-chemo response signal intensity curves. This was the beginning of the chemotherapy. This was just before the first cycle. We appreciate that there is a very steeper curve in the lesion here. And 3 months after the chemotherapy response, there was significant decrease in the steepness of the curve, which suggested that the lesion had become less aggressive. So that was good response with more than 90% necrosis. Last but not the least, metal artifact reduction sequence is a particular software which helps us reduce the size and intensity of susceptibility artifacts. This is particularly useful when patients have metallic implants, and there are multiple methods using which we can do artifact reduction, and some of these are on the screen here. So in summary, MRI is the best tool for characterization and local staging of the musculoskeletal tumors, but we need to use adequate protocol. Seek help if required. Contact your local radiologist or somebody who specializes in bone tumors. Speak to your surgeon, and always be aware of role of contrast, particularly to assess aggressiveness post-chemotherapy changes. Thank you.
Thank you so much, Dr. Seema, for a very clear explanation as to how MRI is going to help us get to the right diagnosis and plan the treatment for the patient. If you could just unshare your screen, I'll request Dr. Reddy Prasad Yadav, who's a consultant interventional radiologist, to share his views on his role in musculoskeletal oncology. Dr. Reddy?
Yeah, hi, Dr. Srimant. Yeah.
Yeah, could you please share your screen and start your presentation?
Can you see my presentation now?
Yes, please, you're visible.
Yeah.
Thank you.
Good evening to everyone, the esteemed colleagues and orthopedic community particularly. And thank you, Dr. Seema, for a wonderful presentation. And also thanks to Dr. Srimant for putting up a wonderful webinar series that's going to go on for the next 4 weeks. Although the title is bone tumors, benign bone tumors, as an interventional radiologist, we are starting, and I'm going to be covering during my talk a comprehensive overview as to what we can offer both in benign lesions and malignant lesions. So we have a fantastic facility under the chairmanship of Professor Dr. Somshekhar, who has got this all under one roof, Manipal Comprehensive Cancer Center. We discuss all our complex cases at the MDT tumor board amongst the oncologist, Dr. Hemant, also surgeon, and Seema and ourselves. Then we come up with a plan. Once the diagnosis from the imaging is performed, then we have to prove what the tumor is. As an interventional radiologist, what is our role? How can we help the surgeons? How can we take the imaging that has been done? How do we take it forward? Our role is one, minimally invasive treatment options, which is ablation. It could be RF ablation or microwave ablation, cementoplasty of particular lesions, preoperative and sometimes postoperative embolization, and much more commonly performed is a biopsy because you need a tissue diagnosis to determine the way forward. So bone biopsy, I'll start off talking regarding the bone and soft tissue tumors first. Why do we need to do as interventional radiologists, why do we need to do biopsies? One, because we perform this through hardly a 2 millimeter hole. We are moving away or we have moved away from a surgical biopsy. There are lots of advantages of doing a minimally invasive percutaneous image-guided biopsy. All the advantages are listed here. Majority of them are on a OPD basis, day care, less cost and less morbidity to the patient, less damage to the bone, quick recovery time, and no scars and lower cost. How do we do these procedures? It can be fluoroscopy guided, ultrasound guided, CT or MR guided. Majority of the time, we as IRs, for soft tissue lesions, we choose ultrasound. For bony lesions, we choose CT. That is our bread and butter. However, if there is a significant soft tissue component from a bony tumor, we might choose ultrasound guided biopsy. That's the essence. Very rarely, we might perform fluoroscopy guided biopsies. And MR is not that commonly used because it has its own challenges. Indications of percutaneous biopsy, when you need pathological, I know this is oncology symposium, but then I'm just going to be comprehensive with regard to IR role. Bacteriological or biological examination if it is required. The indications would be primary or secondary bone tumors, soft tissue neoplasms, osteitis or osteomyelitis, septic arthritis, and discitis. Contraindications are usually relative. Majority of the times we go ahead and give you the biopsy samples. That's not a problem because majority of them can be corrected. If there's an uncooperative patient, we can have an anesthetist present. Cardiopulmonary comorbidities for a biopsy should not be a contraindication. The only issue is sometimes if the biopsy is required from an inaccessible site, particularly from the top 2 cervical vertebrae, then it becomes difficult for us. To start off with ultrasound-guided biopsy, we have a couple of options. Excellent coaxial biopsy guns. Majority of the times we use 18 gauge coaxial biopsy needles with a 20 millimeter or 10 millimeter throw. On ultrasound scan, we real-time guide the biopsy needle into the lesion. Majority of the times the soft tissue lesions or the tumors are hypoechoic, which means it is darker, and hyperechoic can be fat or necrosis within the lesion. It is quite tempting to go into the center of the lesions, but that is when we get negative biopsies. We should try and stick to periphery of the lesions into the hypoechoic areas. Then moving on to bone biopsy needles, commonly used are Jamshidi needles and Cook bone biopsy needles. Either they can have a beveled edge as seen on the left or a serrated edge seen on the right. Technique, as usual, like any other patient, this is a mini surgical procedure. We perform an initial workup, all the blood tests performed, and these days antigen is required or RT-PCR is required. Informed consent is obtained. The procedure is performed in a sterile way. Majority of the times under local anesthesia or sedation. Occasionally, if there's an anxious patient or a deep vertebral lesion, we might need general anesthesia. We definitely give lots of adequate periosteal infiltration with local anesthesia, 2% lidocaine, and then the patient is almost pain-free. And we go ahead and use Jamshidi needle, or there is a new on-drive system, which I'll show you. One important thing is we work very closely with the ortho-oncosurgeons to make sure that our biopsy site and biopsy track goes through your future planned surgical incision. There are several pathways for different lesions and different approaches. However, commonly used in the thoracic vertebrae or either transpedicular or intercostovertebral. In the lumbar vertebrae, it's quite straightforward, transpedicular approach. Fluoro-guided biopsies are occasionally performed. I know orthopedic surgeons would more commonly use this in the theater. This is a guided biopsy of a right humeral cortex lesion in an 8-year-old child. I'll show you several examples of how we do and what we do. This is a CT-guided biopsy of a right femoral cortical lesion using a 8-gauge Jamshidi bone biopsy needle. This is a 10-year-old girl who had a eosinophilic granuloma. It turned out to be a eosinophilic granuloma in the cervical vertebra, and we used a lateral approach. Obviously, the patient is intubated. It's a child, so we have to make sure. And then we get some good course, which will yield the diagnosis, which guides your treatment. This is an oblique way. We have used a 13-gauge Cook needle in a 72-year-old with a rib lesion who had a multiple myeloma. Biopsy from a small sclerotic sternal lesion in a patient with metastatic breast cancer. Now, it has been well established that Jamshidi needles and Cook biopsy needles have been used, but it's also quite daunting when you have particularly sclerotic lesions, and it becomes very difficult. We're using the mallet to hit it into the bone and trying all your muscles to put it into the bone. Either the needle bends or sometimes it is very difficult. Even the orthopedic surgeons try and they use their techniques. But these bone drills, particularly for the interventional radiologists outside your theater environment, has completely changed the game. It is yet to be completely taken by lots of hospitals, but we have started using this over the last 1 year, and life has become much more simpler. And this is made by Teleflex Arrow. It's called On Control. It's simply a battery-operated drill, and it can be used in approximately, each battery-operated drill can be used in approximately 500 patients. So it's very economical as well. The advantages of this are obviously our faster procedure times, rapid access to sclerotic bone lesions, and we get high quality specimens, really high, very good quality specimens. The pathologists are very happy, and this is very easy to use. These are the kind of course we get. Now, using this on-drive control system, we have done several lesions. This is an example of an acetabular roof lesion. This could be done with any needle, but then once you start getting used to it, it is very easy for the patient. The procedure is very quick, very comfortable. This is a vertebral lesion transpedicular approach in a 56-year-old female with metastatic breast carcinoma. Now that's about the biopsies. Moving on to ablation of bone tumors. The ablation technique involves local application of heat to ablate, destroy the abnormal tissue in symptomatic patients. Majority of the indications, I'll come to it, majority of the times we perform in osteoid osteoma. Using image guidance, the electrode is accurately placed in a limited volume of the tissue, and that is ablated without significant damage to the adjacent structures. How do we do it? What are the advantages? It's a quicker procedure time. These can be performed as daycare procedures. We are able to treat the patients who are poor surgical candidates, and the complications are very minimal. Almost there is no blood loss at all. That's the advantage of local ablation. Small disadvantages, it's definitely slightly higher cost, but the more we use, the cost should go down. Availability is limited. Requirement of expertise and infrastructure is definitely a disadvantage, not widely available. And this cannot be used, ablation cannot be used for intra-articular lesions. There are two options we have. One is radiofrequency ablation and the other one is microwave ablation. The technique is exactly the same. The only difference is the generators and slight variation in the cost. A definite advantage of microwave ablation is it's much quicker and much more spherical ablation we get compared to radiofrequency ablation. That's the new kid on the block. Indications for ablation, most of the times it's osteoid osteoma, occasionally painful metastases, myeloma deposits, chondroblastoma for lesions with less than 2 centimeters. There is emerging evidence. Pre-procedure workup is as usual, like any other surgical case. We have to evaluate them thoroughly. Technique, we perform the procedure for osteoid osteoma ablation. Majority of the times we perform the procedure under general anesthesia after obtaining informed consent, strict aseptic protocols. We localize the lesion on CT scan. This is very similar to biopsy. We tend to these days, we use the on-drive arrow drill. Life is much easier, particularly when there is this sclerotic bone. And quite frequently, we use a 11-gauge bone biopsy needle to get to the nidus. Then through that, we insert a RF or microwave antenna and start ablation. Complications of ablation, very rarely neurovascular injury, recurrence or residual nidus, less than 2% of the cases in our experience, and very rarely paralysis in vertebral lesions. So this is a RF generator, and that's what it looks like. That's what an RF antenna or RF electrode looks like. Very similar looking is also a microwave antenna. The procedure is performed obviously under CT scan guidance. This is a recent case that we performed of an osteoid osteoma. That's my team. And once the procedure is performed, when we see the electrode tip, you can see charring because of the nidus burn. Most of the times, if within the bone, if you are within the sclera, not in the correct area, you don't get this charring. You don't see that. This is an 8-year-old boy with pain and swelling in the right thigh region for 3-month duration. Classical findings. Axial CT scan showing central hyperattenuating nidus with a surrounding hypoattenuating rim and very thick sclerotic bone. If I did not have a proper drill, it would have been extremely difficult to go through that sclerotic bone, but it was pretty straightforward to drill through that bone. Obviously, Dr. Srimanth also helps us with these cases, and it was pretty straightforward to do the ablation of this, and the child was asymptomatic on follow-up. This is another small osteoid osteoma in the left greater trochanter. The technique is very similar. The only difference is that sometimes when we have unaffordable patients, recently we have also started doing, there again is emerging evidence for these things, only CT-guided drilling and drill the nidus out, we don't ablate. And there is emerging evidence that the patients have symptom improvement. This is a 27-year-old male. The interesting thing about it is initially we thought this was an osteoid osteoma. However, we send biopsies of these samples prior to the ablation, and this turned out to be an osteoblastoma. The patient, in spite of after ablation, he persisted with his symptoms. So Dr. Srimanth cleared out this lesion. So just a variation. Now, having completed the ablation techniques, moving on to what we can offer as for embolization. In hypervascular tumors, on the right-hand side, you see a large lytic lesion within the femur, proximal femur. This is something obviously that you would go on and insert either an intramedullary nail or a DHS. Most of the times, intramedullary nail, you don't want bleeding in these cases. On the left-hand side is an image of the scapular lesion. On the left-hand side is a femur lesion. What can we offer? What is the advantages of embolization? We reduce the tumor vascularity and intraoperative blood loss and reduce the need for blood transfusion and thereby associated complications. Definitely a better definition of tissue planes at surgery, affording more complete excision and hence reduced recurrence. And there is also increased sensitivity of some tumors to subsequent radiotherapy. Indications obviously for embolizations are preoperative and postoperative blood loss reduction. We also help with pain relief in bone neoplasms and palliative care of bleeding vascular neoplasms. Different varieties of embolic materials that can be used are coils, PVA particles, glue, sponges and gel foam. Onyx is a costly embolic material. I've just put in that name there, but not frequently used. Most commonly used are PVA particles and glue. Commonly embolized are hypervascular metastases, particularly renal cancer and thyroid malignancies. Occasionally aneurysmal bone cyst. Recently, we embolized a giant cell tumor before Dr. Srimanth operated on that patient. Occasionally aggressive intraosseous hemangiomas and intraosseous AV malformations. This is a young 25-year-old doctor who had a right scapular lesion involving the glenoid surface. And we embolized this, came from the femoral artery through the subclavian and axillary artery, went into the circumflex artery, and very good embolization using PVA particles. That reduced the blood loss significantly. And I'm sure the Dr. Srimanth will tell you that the surgery was pretty straightforward and smooth and bloodless. This is an example of a large RCC met completely destroying the proximal femoral shaft. This was embolized with PVA particles. Now, completing on the embolization, moving on to very briefly other role of interventional radiologists, what can be offered. I know some spine surgeons and orthopedic surgeons also do these procedures. There is an overlap. Is cementoplasty. Essentially, if we can get the needle into the lesion, we inject some cement. It could be for metastatic lesions, particularly metastatic painful lesions, where you give some support by giving the cement. And definitely, there are lots of patients whose pain is improving. And occasionally, painful osteoporotic vertebral fractures. There is a debate going on in the West, whether really vertebroplasty works or not. That's a different topic. But there are definitely certain group of patients who get symptom improvement with this procedure. You don't need me to show you how to prepare the cement. You're all the experts. I'm just moving on from there. And once we get the needle in place, we inject the cement extremely carefully because we don't want any cement leaks. There's another case, patient with lung cancer with vertebral metastasis, cementoplasty performed. Acetabular a component where there are osteolytic lesions in the weight-bearing area to prevent fractures, cementoplastic can be performed. It can be performed. This is pretty straightforward procedure, easily done. In conclusion, interventional radiology has a lot to offer with regard to minimally accessible solutions for all your complex MSK oncology problems. And so we work very closely as a team, Dr. Seema, MSK Radiology, Dr. Srimanth, MSK Onco, orthosurgeon, interventional radiology, oncologist, radiotherapist. We have a big team performing extremely well in the Manipal Comprehensive Cancer Center. And although he's not here, Dr. Somshekhar does a fantastic job getting the team together. Thank you.
Thank you, Dr. Reddy, for a very concise talk on the role of interventional radiology. So could I just ask you to unshare your screen, please? Yeah. So the last talk for the day for this session is going to be a giant cell tumor. So giant cell tumor treatment and what is the treatment armamentarium is what I'm going to be talking about. Is my screen visible, Amit?
Yes.
Yeah. Thank you. So greetings again from Manipal Hospital and Manipal Hospital Comprehensive Cancer Center. I am Dr. Srimanth. I am the surgeon who handles these cases in the hospital, more of bone, soft tissue, and bone metastasis. So my topic is going to be giant cell tumor of the bone. Why giant cell tumor of the bone? Because this is one of the most commonest type of tumor which we do see in our practice. And this is something which we feel surgeons should know how to handle and how to manage them and also follow up the same patients. Just a minute. Yeah. So Campanacci grading for benign bone tumors actually help us out a lot with the treatment options. So there's grade 1, grade 2, and grade 3. What we are worried about is grade 2 and grade 3 tumors, especially the grade 3 ones with large extraarticular components. So for Campanacci grade 1s, it's a straightforward job. We do an extended curettage. They have very good subchondral bone. And we take in a lot of options like bone grafts, bone cements, sometimes many of the surgeons don't even try to fill the cavities also, and they tend to heal very well. The reason is giant cell tumors are pretty vascular, and they heal more often if you have a biological containment. But grade 2s and grade 3s are a big challenge. Like you can see here, we have pretty bad subchondral bones, collapses, extraosseous soft tissues, and pathological fractures. So this tends to make life a bit challenging for us, because we need to make sure that this is still a benign tumor, and we need to get the best possible outcome, because this patient is going to live long, forever, as long as it's possible. So what is the operative principle for me when I treat benign bone tumors? I always try to keep a balance between having the best functional ability, but at the same time making sure the disease is cured completely. So it's actually vice versa. So the disease clearance is done by curettage or resection in certain unavoidable cases. Whereas, we try to reconstruct it by biological methods using bone grafts or cement, or in certain cases where its resection is done, we might even do a prosthetic or a composite reconstruction. So how do I get this right? Patient selection is extremely crucial as to what you're going to do. And two important characteristics for me is the soft tissue involvement and the subchondral bone limit. These two are good limiters for me as to find out what is the best mode of surgery I can offer to this patient. So this is a very straightforward case. A Campanacci grade 2 GCTB in a 54-year-old male patient underwent an extended curettage, cementing. This is more of a secondary giant cell tumor. You can even see the aneurysmal bone cyst component also. So the whole component was excised, curated, and extended curettage was done, and cement was put, and this is a 4 years follow-up. So now the big question is, how did we get this outcome, and what was the steps? So just to take you through, we have another similar typical grade 3 Campanacci lesion. Subchondral bone minimum, anterior expansion, minimum soft tissue. So you can see here there's a breakout of the cortex here, and it's trying to move across onto the anterior compartment, and most of the bone is involved with very thin subchondral bone. So what I do here is, so this, I do a curettage with the curettes, and then the most important component, what I can see here, is a high-speed burr. And this is helped a lot in reducing the local recurrences, as much as less than 16%. In our audit, it's less than 3%. And I think the current evidence portrays anywhere between 3 to 10% on the use of extended curettage. So high-speed burr, again repeating, is the most vital component after a curettage to reduce the risk of recurrence in a giant cell tumor. So is there any evidence for any additional usage or adjuvants which can be used? Actually, there is no level 1 or level 2 evidence to actually advocate the usage of any of the following, like alcohol, sclerotherapy, phenol, cement, or liquid nitrogen. Each has its pros and cons, which has to be selected in. Often the surgeons who use them, or the articles which have come out, portray a lower recurrence rate, but it has its fair share of complications. So it's more surgeon dependent. But is there a dictum to use one adjuvant over the other, which is the best? There is nothing as of such. So what I do is I use hydrogen peroxide, which is helps reduce the bleeding and gives us a good clear margin, and helps as a tumoricidal drug also. And at the same time, I use something called as an APC cautery, which again is something where we cauterize the walls of the cavity. And post this, we use a pulse lavage to take out all the debris. And this, you can see here, is the final picture post curettage, where you can see nice healthy bone and no disease tissue. And this is a small highlight here. It's not a window, it's actually a door where we try to get into the tumor. So this is how the whole reconstruction is done, a composite reconstruction with cement and plate and iliac crest to build up the subchondral bone. And this is 3 years follow-up X-ray. Similar picture again, a very bad lesion, literally no bone at all, very thinned out cortex, but looks very subtle on the X-ray here. So this patient also underwent an extended curettage, reconstructed the subchondral bone with a thick iliac crest, and then use the cement and the plate. So what I have learned is that there is no substitute for surgery in any grade. So the extended surgery should be good, and extended curettage should be really adequate, and that's what is going to help us get the best results. Certain times we even have patients who have pathological fractures. And so these patients, what do? It's not right on our part to try to excise these lesions. And since it's a young patient, we go and do an extended curettage again. And we use the patient's same on autofibula because the patient did not consent for an allograft. So autofibula was used, and this is the picture after 3 years. So again, pathological fractures in giant cell tumor. is a selective indication, but it is not a contraindication to do limb salvage or save the bone. What do we do in situations other than the knee, which is one of the most commonest, like in the distal radius or in recurrent situations? I do something called as a recession arthrodesis in these patients, and they do pretty well. Again, sometimes we do face challenges like such a big tumor, which we can see here. And in these, it's not only me, it's actually teamwork, where I get in my radiologist to find out what are the tissues involved, what can I save. So this 26-year-old lady with a grade 3 Campanachi with such a huge mass and radial artery involvement, we excised the tumor. We had our plastic surgery and microreconstructive team who helped us with trying to take a free, live fibula with a soft tissue paddle. And this was anastomosed with the radial artery distally and proximally to retain the vascular arch. And once the wrist arthrodesis was done, all the extensor tendons which were involved in the tumor were reconstructed using tensor fascia lata strips. And this is how the patient is after 3 years with a minimal, disability or a differently ability, but the patient is still comfortable actually riding a two-wheeler. And then that gives us more onus to do a comprehensive care in such complex situations. Again, certain situations not amenable to salvage, like this case, a proximal humerus giant cell tumor with a big soft tissue mass and quite a lot of destruction of the bone. And this would probably require a tumor excision and a prosthetic reconstruction with a decent enough follow-up. The small highlight here is that this is a straightforward humerus resection. In such cases where we can save a lot of glenoid, and if the axillary nerve can be saved, most importantly, we can actually use a reverse shoulder tumor process also, which will allow shoulder abduction, compared to hemiarthroplasty shoulder, which does not allow shoulder abduction or may allow minimal movements. Certain situations, again, like pathological fractures where we cannot save the joint, is such big tumors here, where we can see that there are multiplanar fractures, extraosseous soft tissues, minimal or no subchondral bone. And this patient underwent a resection and a tumor prosthetic reconstruction. So again, there's a plethora of options where we try to see how much we can try to save the joint. The younger the patient, the more the bone stock available, the onus is again on us to try to provide an extended curettage, because we know that this patient can afford a recurrence in certain terms, but that is again with counseling. We also have a wonder drug which came up in the last few years called as denosumab. We've had a mixed share of exposure with denosumab, where it has helped us in a few situations and it has not helped us in a few situations. My role in this sort of scenario was I had landed up with a recurrent giant cell tumor, which was operated outside. So this young patient came down to us and we said, okay, yeah, there is a subchondral fracture. Let us try to build up your articular surface. Let us try to see if we can get your weight-bearing area intact. So we gave him 4 doses of denosumab. So post 4 doses of denosumab, there was a pretty good bone formation, but unfortunately, this patient recurred after the second curettage, and you could see here the burring pre the curettage and the post burring. This actually looked near normal, but there is enough evidence which is coming up which now says if you use denosumab in majority of the cases, often you will land up with inadequate surgery. That means the extent of curettage, even with a high-speed burr, is somewhat limited for the surgeon. So the recurrence rate has actually increased to anywhere between 30 to 40%. So again, use with cautions in such situation is what we try to put across. At the same time, pelvis, yes, pelvis is again a different way of looking at things. When we look at benign, you can see here that we do extended curettage and cementation on bone graft. At the same time, denosumab, zoledronic acid, or surgical options such as hemipelvectomy has also helped us a lot in such situations. So yes, denosumab did help me in the other lot. How did that help? There was this patient here who had a pretty big soft tissue mass coming out from the inferior ramus and the ischium bone, which turned out to be a giant cell tumor. This patient was given 4 doses of denosumab. As you can see here, progressively, there's a nice solid shell which is formed. So we counseled this patient, did a resection or a type 3 partial internal hemipelvectomy, and the posterior wall and the column up to the suprastabular area was curated, and the cementation was done. And this patient is comfortable post 3 years follow-up also. So yes, Denosumab is a wonder drug, but at the same time, there has been enough literature which is coming out now and which will come out later also, which allows us to actually try to selectively use the drug to make sure that we get the best results out. In certain situations like inoperable cases or cases where there is a huge morbidity, we do know that there is nothing else which we can do. So we try to combine both embolization and denosumab. The only issue here is we don't know when to stop the denosumab, and the evidence now is somewhere portraying between 3 months to 6 months, but there is a lot more studies required or patient data required to tell us when can we stop it. So this patient was on denosumab once in 6 months. So post 48 months, you could see that the patient's tumor had become a bit sclerotic in the margins, and she had gone back to work. But unfortunately, for financial implications, the patient could not take it for a continuous period, and we're trying to look at and helping them out to get back on the denosumab and embolization also. So again, yes, inoperable tumors, axial skeleton, pelvis, we can use denosumab to try to help the patient also. So just to see what is the latest review and impact on practice on denosumab, we definitely need to individualize. There is no definite dosage, schedule, and duration, but 120 milligram per dose for 2 to 3 doses is deemed to be effective in patients nowadays. And there is a malignancy risk, yes, but it's small. So, trying to make sure that these patients also are not under any calcium abnormalities during the treatment also is very important. So my takeaways on giant cell tumor treatment armamentarium is such that never assume giant cell tumor to be GCTB on radiology. Always image and biopsy. This is where we often tend to see oops cases coming across to us in our team, and they often land up with osteosarcomas or chondrosarcomas thinking it's giant cell tumor. Always rule out Brown's tumor. How do we do it? Try to do alkaline phosphatase and serum PTH levels to make sure that it is not a Brown's tumor that we're dealing with. Extended curettage is the mantra. There is no solution beyond it if you are going to do interlesion surgery, which is the most common surgery done again. Try to salvage. Resection is always a backup option. You can see here on the right side, there is a patient. This patient had a recurrent giant cell tumor in the distal tibia, as you can see in the lower corner image. And there was a big infection, a big scar, and there was quite a lot of pus coming in. And this patient was counseled, and we did a resection and nail cement plate spacer, arthrodesis, and a free ALT flap. And that's how the patient is able to walk and try to be mobilized. And use denosumab selectively. Yes, there is a definite role. And I would say in my situations, if I need to operate on the patient and remove the tumor or resect it, I would definitely use denosumab. And in axial situations where it is not operable or the mobility is high. And definitely embolization is a very useful tool which can be used in axial or spinal giant cell tumors, or even places such as the humerus and the proximal femur. Thank you so much. So I'd like to end this presentation here. So we are coming to the end of the meeting where we shared our views on benign tumors, radiology, interventional radiology, and giant cell tumors. Can I request Dr. Seema and Dr. Reddy to come online, please?
We are here.
Yes, sir. So if any questions are there, we'll be more than happy to answer them. Any questions from any of the participants? Yeah, so we have not got any questions. If you do get them, we will be more than happy to share it across. I had one question to Dr. Reddy. As an intervention radiologist, how would you put across the impact which CT-guided ablation for osteoid has helped the children? Do you feel that the improvement has been stark, or do you still feel there's a role for surgery in such situations?
Thanks, Dr. Srimant. So I think there is enough evidence, and it is kind of done and dusted. What you do with surgery by excising, ablation has significantly, there has been a big paradigm shift. Children, young adults, whoever presents with osteoid osteoma, if we get the technique right, and if we can get the nidus burnt correctly with a proper technique, the recurrence rates are extremely poor, extremely low, and the need for surgery or repeat ablation are extremely rare. So ablation, not just in the bones, in other tumors, liver metastases, there is significant evidence throughout the body in different parts, in solid organs. We know that ablation works. Similarly, osteoid in bone lesions, both in children and young adults, it works extremely well. We just have to make sure we get majority of the interventional radiologists, all of them. They do a great job. So, and the big advantage is we are doing it under image guidance. We know precisely that the tip of the needle is at the nidus, and we have to make sure we burn it properly. The other thing is we know from the generator, also the microwave generator or RF generator, it will not pass any radio frequency waves or microwave waves if we are not in the correct place. With the impedance and resistance, it will auto shut off. Only if we are in the correct place, it will burn properly. So it is making sure that we do a satisfactory burn, then the recurrence rates are extremely low.
Thank you so much, Dr. Reddy. There's been one question wherein the participant has asked for criteria for embolization in giant cell tumor and results. As a surgeon, if I want Dr. Reddy to be involved, my criteria for embolization is one primarily in spine tumors or pelvic tumors, which I might not operate on. Okay. And the second indication would be when I want to operate. So what are these lesions which I want to do embolization? Proximal humerus and proximal femur and pelvis are three most important areas for me, and also the spine if I want to operate, where I would like to do a preoperative embolization to reduce the vascularity, because most of the other places distally we can use a tourniquet. Also, denosumab again has to a certain extent shared the role and also reduce the need for embolization in certain situations where we might feel that the tumor spillage also might increase the bleeding. So denosumab also what it does is it allows a good shell to be formed. So again, it also reduces any chance of tumor breakage, because they are actually very soft tumors or boggy tumors when we actually handle them, and also prevent the bleeding. So these are my three criteria for embolization in giant cell tumors, and the results intraoperatively has been fantastic. The bleeding is next to a none, because these are very hypervascular tumors, and it helps out a lot for these patients. Any other questions for the participants before we close this session? Mr. Amit, have you had any questions coming in? Can we close the session if there are no questions?
There is no questions, doctor.
There's no questions there. So, okay, Dr. Neeraj, I think we are done with the program. Any questions or messages to you, sir? Yeah, so we've not had any response there. So we'd like to end this program, and I'd like to share my thanks to Manipal Hospital and Cancer Center and our team who's been helped out to start this webinar series. So this is a month-long program, and we'd like to share the invite again and intimate you as to the next program. So the next program is going to be on the 12th of December, and we're going to be having a session on bone sarcomas. So we're going to have a comprehensive team session on bone sarcomas, and looking forward to meeting all of you then. So thank you so much, and we're going to log out now. Thank you again. So Amit, we can log out, please.
Doctor.
Yeah.
Thank you.
Thank you. Yeah, and one more thing is that I'd also like to thank OrthoTV for their assistance in helping us to reach out to more participants or viewers also. Thank you, Dr. Neeraj. I think we're not able to get him on. Okay, thank you all.
you.